Hey everyone. So welcome to the ATS Critical Care Assembly Early Career Professional Working Group uh, talk. We're talking about career transitions today, and we are joined by Dr. Diego Marin. Dr. Diego Marin completed his bachelor's degree in biology at Nova Southeastern University, followed by his doctor of osteopathic medicine, completed internal medicine residency at Bayon Medical Center, and then a fellowship at Newark Beth Israel Medical Center, and then worked at HCA Florida West Side, but also private practice at Pulmonary and Sleep Associates of South Florida before joining faculty at Florida Atlantic University. And he's going to share with us his experiences working in private practice and academic practice. Thank you so much for joining us, Dr. Marin.
Of course. Thank you for having me. Thank you to Priscilla for inviting me to do this after, we met at ATS. And I'm happy to share this perspective that, after we had our discussion, I guess is not something that everyone really has a lot of information on. I mean, there might be some spread out, but, there's a variety of things that are on the more clinical practice type of settings that I think I'd like to kind of go over. Now, this is going to be very, very narrative, and there's going to be a lot of details that I think are important. It's a little bit more tailored towards like what I think I would have wanted as a third year fellow looking for jobs. So just to kind of give you an idea of how we'll proceed, I'm going to put some information about me. We're going to talk about like the three practice settings that I've had since fellowship. So starting with HCA, which was critical care shift work only, then private practice, which that's my little guy Avery at his first birthday. That's what I thought I was going to look like as a private practice attending, real dapper. And that was a mix of pulmonary and critical care practice. And also I had a title of director of interventional pulmonology. I am not fellowship trained, the extra year in fellowship for IP, but I did have IP experience, which we'll talk about. And then now I'm at the VA, federal employee, what that life is like. And that's also a mixed and pulmonary care type practice. So a little bit of like very, very different practice settings. Mind you, I'm usually not a presenter that likes very wordy slides, but unfortunately, some of these topics happen to be a little wordy. So I have to apologize. I usually just like pictures. So about me, I'm Costa Rican, originally raised in Miami and Broward County, trained again in Newark, Beth Israel, heart and lung transplant and ECMO center, very high acuity, a lot of fun. I got a lot of IP experience. My program director did a lot of IP, as did some of the transplant attendings. So I got to cannulate. So I have ECMO cannulation experience. This is one of my cases that I did for a anastomotic stenosis there. So I got to do some ballooning. We had cases with 3D stents, metal stents, a lot of really cool stuff. This case, this is a whole nother discussion. That's a ripped posterior membrane that you can see there. Just a lot of really sick people. And here's some explanted donor lungs. So jumping right into it, I was looking for work and my wife was super pregnant and we were moving back home to Broward County from Newark, New Jersey. And I looked at this job. It was back home. It was actually like right by Nova Southeastern, where I went to med school. It's literally like the second closest hospital because there's actually one on the campus. And it sounded like a really good job. Now, I wasn't sure because, like I think many people, I went into pulmonary and critical care with a lot of critical care enjoyment and, the acuity and the craziness, and fell in love with pulmonary, which I realized real quick was one of the things that I was missing here. But the work was really, really simple. It was 5 shifts of 7A to 7P, 5 shifts of 7A to 7 or 3P, like a short shift, because there was 2 people on each day, and then 7P to 7A. And it was, hi, Bobby. There it is. So the work, hi, Bobby, I'm presenting. I'll see you in a little bit. So the work was pure hourly. It's 205 an hour. That was at that time. And it was an average of 2,080 hours, which when total was about 426,400. Overtime was allowed. And actually, we'll get into some of the issues with this type of setup where you were never really done at 3 p.m. And really it dragged on to like 4, 5, 6 p.m. sometimes. So my hours ended up being a lot more than what you would expect a regular 2,080 hours a year. Mind you, that's like an usual 40 hours for 52 weeks. There was also a stipend for education that was time spent outside of the ICU, where this was with the residents. So technically, like from GME, and that was $150 an hour for an up to 10 hours a month. Now, I love teaching, which is one of the biggest reasons I took this job too. They had residents. I said, anywhere that I go, I have to have residents. I love teaching, it's a passion. So being able to actually be paid a little bit extra for spending that time with like mentoring and like coming up with projects, making posters, and making presentations that fell outside of just like regular education on rounds. That was something that I really enjoyed, and hey, brought in a little extra money. I mean, that adds up to another $18,000 a year. So first year earnings were about $450,000, and it only goes downhill from here. But so great money. It was very, very flexible. The Going into the contract negotiations, there wasn't really much to negotiate. It's HCA, which I don't know if you guys are aware, is technically the largest for-profit hospital system. They own what's called ICC, Intensive Care Consortium, and they are basically the ones that employ all the intensivists and staff the ICUs. So you can't really say, well, I don't like this wording. They're going to say everybody else has that contract. It's more of a take it or leave it type of situation. But some things were negotiable. The biggest one being sign on, which originally they offered 30. I said I want more, and they agreed. So I got 40, and then relocation of 10,000, which that was pretty much their max. They said this is just what it is for relocation. And obviously, coming straight out of fellowship, I did 1 month at Newark just to make a little extra money before I moved because my wife had to finish off her own private practice contract because she's family medicine. And it worked out really, really perfectly. They were really super friendly. I got flown down here. I had a hotel for 2 nights. I got a rental car, like very, very nice interview process. So that was kind of the experience getting into this job. And I looked at some other positions around the area, but this one kind of fit the main things, which was it was great money, very flexible. I was about to have a baby, and being close to home was important. So also because of the pay, I try to ask for more than 205. And the one thing I'll tell you about negotiating contracts is whatever you want to ask for, it's not like they're gonna be like, "Ah, I can't believe you're so greedy and asking for that." Like, no, ask. There's a saying in Spanish, el que no mama no llora, el que no llora no mama, which basically sounds like the children, the ones that don't cry, don't get breastfed, right? So if you don't ask, you'll never know if they'll agree to it or not. And they might meet you somewhere in the middle. Like, don't ask for 300 an hour. Basically, you can ask for a little bit more. Then because they couldn't give me, I wanted 225. They said no. They said, what we can do is we can negotiate you down from a 3-year contract to a 2-year contract. And then that means you can negotiate for a higher pay at the 2 years, so a year earlier. And I said, okay, I'll take it. This is, I keep a lot of records and I like to be very mathematical. So this is a actual sample of what a 3-month period of time looked like working this type of scenario. Now, it's 15 days out of 30. It's just exactly how it works, right? So it was 6 intensivists, 2 during the day, 1 at night. Now, if you think about what that means for the weekends, that means you work 1 out of 2 weekends. It has to be that way because 3 people have to work every weekend. There's 2 people during the day, 1 person at night. So there's also 5 nights, which usually they were kept in a row, which you can see here. I highlighted them and everything's like color coded, makes it easy, I think, hopefully, to see and understand. And one of the things that I'll kind of throw in there is you'll see certain shifts sometimes are like 14 if things happened that at a particular critical care unit where there was maybe just an APP at night or it was phone coverage. Obviously, if something was happening towards the end of the shift, I wasn't trying to get called back. So I would stay and make sure everything was extra tied up so that I got less phone calls during the night. And thankfully, I actually never had to physically go in for anything. There was some great coverage, but these are things that you want to start thinking about if you're looking at this type of scenario is, even the short shifts, like, yeah, it might be scheduled to be only 8 hours, but in reality, it's 9, 9.5, 10, maybe even longer. And your 12-hour shifts, we know, even just in fellowship, 12-hour shifts are never exactly 12 hours, right? They're more like 13. So, there's always that there's always someone that codes at 6:30, so then you're not gonna leave it as soon as somebody comes in, like, all right, good luck, right? You want to tie everything up. The good thing about an hourly pay is that that gets paid, and it's not overtime pay, but it is, you're allowed to do more time. So whenever I put in my timesheets, I was able to be paid for that time that I spent extra in the hospital. There were days where I stayed till like 8:30. I didn't leave right away. So this worked for a really long time, and it was not that bad. If you look here at the 30th, I don't know if you guys can see my cursor, from the 30th to the 9th, get all this time off. Why? I just asked, right? I said, hey, I'm trying to go take a vacation. I'm trying to go to Europe. I'm trying to go to Cali, whatever it may be. Boom. The problem is it's always 15 shifts a month. And here there's a little bit of offset. Some things could be carried over from one month to the other. So sure, you can get your 10 days off in a row, but of the remaining 20 days, you're going to work 15 of them. And if that means you got to do a bunch of shifts in a row, you're going to do a bunch of shifts in a row. Theoretically, you could work 15 days straight and take 15 days, but 15 days straight gets a little exhausting, especially being at attending is a little bit different. So that was good, the flexibility, but it came at a price because there is no PTO. It is just 15 shifts and you got to work them. And in one emergency or another, maybe you can get like a little bit less, but then it's always kind of expected because there's always the same amount of people and any slack has to be picked up by the others. And that's kind of true across the board for most jobs. So again, the pros, super flexible. You can take the time. I had a bunch of days just home. Again, 47 out of 94 days, right? That's exactly a 3 month period. I got to be home, hang out with my newborn, help with the newborn, right? And I loved the co-workers. It was a very like young, like pretty freshly graduated attending. So a lot of, interpersonal relations. These people are still my friends. I still talk to them. We had residents, which is something that I really wanted, so I can continue to teach. Again, that GME concept and still being connected to that and actually being reimbursed for teaching, which is really nice. And the acuity was actually really like pretty decent. It was a little bit lower than training, but I think that's kind of expected when you go into the community. But I still had plenty of what I want to say, like almost like mental stimulation, where I felt that I was doing like a proper job with sick patients. Cons, though, again, no real vacation. There's no PTO. If you need 15 days off, you'll compress the other days. It's 1 and 2 weekends. Every other weekend you work. Now, mind you, if you look back, and I'll post these all together, all three types of practices towards the end, but always 1 and 2. So you may work 3 weekends in a row and get three off. Like it'll average out. But to know that you're gonna basically work 1 and 2, it got a little old after a while, especially with my wife doesn't work weekends. So then she's alone every other weekend. And that kind of gets a little tiring, especially with baby. And the 5 nights a month, yeah, same thing. You'd sometimes have two here, three there, but the nights can get a little exhausting. The short shifts were never really short because you still have to split the list. And it was a pretty high volume. Again, the acuity maybe wasn't that crazy, but it was a lot of patients. It was a 34 total unit beds. So sometimes we'd start with 18. There'd be some extra people in the ER, and then we'd have 4 to 6 consults a day each sometimes. So it would end up being, what they call like patient encounters, like how many people you actually are evaluating. And it would sometimes end up being in the low 20s, 22, 23, 24. And that's pretty busy to keep track of that. And again, to doing that for a couple of days here and there, sure. We saw 30 something patients during COVID time, and that's okay for a short period of time. But to do that consistently, it gets a little much. And the biggest con, which is you're an HCA employee, right? You're very, very replaceable. And there's a story of someone that I know that is very good, that was an HCA employee, critical care, and they kept getting raises until they just decided they didn't really want to pay for that person anymore. And then they just, didn't renew their contract. So there is a little bit of like lack of connection and loyalty. You are definitely 100% a replaceable employee. So that is a con. So I got a lot of time to like do things like this, hang out with baby. He was very little. So that was definitely a big pro for me being like a brand new dad, being able to spend that time. So how did it then transition to okay, so I want to make a change. We talked about the cons, and really what ended up happening is I realized how much I missed pulmonary. I thought I could be without it, or I thought maybe I'll sprinkle it in, but the opportunity never came to like per diem pulmonary, which I did look into it, just like covering here and there, maybe in the clinic or inpatient. And I thought, man, I know how to do all this really cool bronchoscopic stuff, all this like really cool procedures, and I have no way to do them here. And I really missed doing them. I had a patient with what I thought was massive hemoptysis. I'm like, hey, I need a uni blocker. And everybody looked at me like I had two heads. And it was just, they're like, what? And I'm like, why are you looking at me like that? And I said, I need a real bronchoscope. And they also like, were like, oh, we don't even know how to get that. Like, ah. So, those things were frustrating. When pulmonary things came up, I did not have what I felt like I needed to take care of my patients in a way that I felt that I could. So I started looking at not for profit. Why? So I have $440,000 student debt. This is, by the way, there's going to be a lot of transparency here, especially income transparency. And I think it's important for this topic so that you guys can really see the other side of it. So $440,000 is no small amount. Suddenly, my 3 years at a for profit residency counted. This during the COVID period. So I went from 3 years out of 10 for loan forgiveness to six. So now I'm like, oh, I could just do 4 years of not for profit. So I really was focused mostly when I was looking towards not-for-profit opportunities until actually my wife said, hey, look, there's this place, you should have a conversation with them. And I started talking to private practice, which we'll get into now. Important to know when now you're on the other side with these contracts. So I put it there as a cost of business. So I cut my contract to move to private practice in I gave more than 3 months notice, which was necessary, which is really important because you want to leave on good terms whenever you leave a place. But I gave way more than 3 months notice. But because I finished in February, technically I think January, and I started the next job in February, I had signed starting September. So that's a couple of months there. So I didn't finish the full 2 years. So they amortized or basically split up the sign on bonus and the relocation. And I owed HCA $11,122.73. So I had to cut a check for that. So that was the price of me leaving early. Again, I felt that I had waited plenty of time, and we'll talk about how I couldn't get that as a sign-on check in the next place. But these are the types of things that you want to think about when you get into these contracts, is especially really long contracts, 3 years, like that cost would have been higher, right? It was out of the 40, 50,000 technically that I got, to only have to pay 11 back was okay. But I mean, these are not small figures. So I started looking at this private practice. So mixed pulmonary critical care. They have two offices, but they're mostly really at one. So nice one main location for outpatient consults. They have one inpatient consult service, just one hospital, which is the main hospital that they go to. There's one long-term acute care hospital where they see vented patients. There's 4 ICUs across 3 hospitals. So it's a lot of different ICUs. And two have nighttime attending coverage. The other two have APP coverage. Actually, one overlaps both ICUs with one nighttime person. Just from looking at that, that's a lot of ICU. And sure enough, this is a business which has hired critical care only people, kind of similar to HCA, to supplement all of the ICU coverage. Now, this was a great position because it came with a faculty position. It was residents. They were connected to Florida Atlantic University. There was an incoming fellowship. As soon as I heard that, my ears perked up. I love working with fellows. I had been working with residents, and I'm over here trying to, throw out trials and stuff, and they're looking at me again like with two heads. So I really wanted that like a little bit higher like thought process and thinking that I could do with like fellows. And this was for me to start in February, and the fellows were going to start in July, brand new fellowship. So the excitement of like being able to help with a brand new fellowship, I had just come off being chief. So I said like, well, I could definitely help out with a lot of respects for our schedules, etc. So it's a 3-year partnership track, and you work exactly like the partners, quote unquote, and everything is split. So that's one thing that was important for the negotiations. This one's wordy, but it's important to go through all this because obviously this is the most important negotiation out of all the three because there's no VA negotiation. So what was presented was a salary of 380,000. I asked for 420. They said no. I asked for 400. No. So that was just a no-no, right? This is what it is. This is what we got. And the response that I got was, we stress productivity. We'll talk about what that means. So basically, that was not approved. Year two, it went up to 390. Year three, it went up to 400. So there was a 10,000 a year increase as you progress towards hopefully partnership. There was incentives bonuses, which we're going to talk about in detail. And one of the things that I brought up is I said, well, I want to come and do these IP procedures. I want to have a robot. I want to do EBISIS. I want to take care of like really sick patients. I want to like if there's stent cases, they had stents available. They had a thoracic surgeon that was pretty active. So the opportunity, the patient population was there that needed these services. So I said, if I'm gonna make this happen, they told me we don't do a lot of bronchoscopies. They have the EBIS even they sent to a thoracic surgeon. Most of the biopsies with the robot they sent to a thoracic surgeon, and they told me the thoracic surgeon honestly doesn't really have much of an interest in to keep doing these. That he wants to operate, which I get it. In the practice settings I came from, the thoracic surgeons just did surgery, right? They didn't do bronchoscopies, so it seemed like it was going to be a really good fit for me to come in and do the actual bronchoscopic stuff. So I said, having had that background of the GME, I said, well, I need administrative time and I want a title. And they agreed. So I said, I need 20 hours a month, so 4 hours a week, where I can actually spend to dedicated time talking to the people in endo, talking to the people in the OR, talking to the reps for devices, right? If I need to talk to, anyone else, the COO, the CMO, coordinating time slots, like all of these things take time. And I wanted to be paid for that extra time that I was going to spend doing these things that is separate from the rest of the working partners and separate from anyone else that did this type of thing. So they agreed. So 20 hours, 150, so that's an extra 3,000. So really this adds up to 416,000 in the first year. I asked for a sign-on bonus. No. But I want a sign-on bonus. No. So the response there was, well, that has to come out of everyone else's pockets. It was fine. So I couldn't just jump from that 11 grand that I had to pay back. I was hoping I could get a sign-on bonus and just kind of pay it off. Not that it's like super important to this, but one of the things that they did do is they kind of, it wasn't super necessary, but I like that they did it. They kind of basically loaned me that amount and then took it off pre-tax from my paychecks for a year. So that worked out really well because I actually didn't have to pony up the 12 grand or 11 grand. And because it's pre-tax dollars, it kind of saves me on the having to pay post-tax. So it actually ended up being a really nice benefit, which I didn't even think that was a possibility, but they were able to make that work. So this came standard 20 vacation days a year. It told as unlimited as a partner. You just take less pay because you produce less. And again, we're going to talk a lot more about that. 2,500 CME, which I think is not bad. $150 a month in car stipend, which I thought, oh, that's a nice benefit I've never seen before. And $100 a month for a phone stipend, which you could use on your own phone, or you could just pay another line if you wanted to have a completely separate business phone, which I also, again, it's not that much money, but it's still something that was nice as a benefit. So this is some of the bigger ticket items. So there was some language in the contract, which let me show you. So this is my lawyer, very professional. So he said, listen, there's language in there that any products or anything like that that you produce while an employee technically falls under them. And I know a lot of academic type positions are like that, right? So if you invent some kind of crazy new device, technically it's your employers. There's a little bit of like issues there. So I wanted to work locums if I wanted to. There was a place that needed locums down in South Miami, and I was like trying to figure that out and sign on to do that. So we changed the language so that I had complete freedom to do any consultant work clinically anywhere else, as long as it wasn't obviously within like geographic area. I could lecture. All these things were completely wide open for me. So we opened that up as part of the contract. Important part two is the tail malpractice coverage. So there's occurrence based, for those that don't know, for malpractice purposes. And then I forget the name of the other one. But occurrence based means you're covered because you had insurance when it happened. The other one has no tail. So as long as you stay in the same job, you're fine because you work at the same job, so you have the same insurance. But if you were to ever leave, then you need to pay for continued malpractice coverage after you leave and no longer pay premiums because you no longer work there. So, and then that's at least for the statute of limitations of whatever state you're in. So in there, contract, they had it was 100% on me if I left within 12 months, 50-50 between the practice and I if I left in less than 24 months. And if I left after 2 years, then basically the group would pay for everything. We partially agreed on that. I spoke to the lawyer and he said it needed to be added that if they terminated me without cause, then within a year, then they basically couldn't blame me for the have me pay the full malpractice. It had to be 50-50. And understanding the situations of how you could be fired for cause and without cause are very important. And I have a nice long document that talks about that. And again, I'm gonna put it, you'll see it there. I spent $850 because it's like an initial consultation with this one particular lawyer. I will easily in the future, if they're ever come in a situation like this, pay $2,000 to $3,000 or more for a good lawyer who actually understands the situations in which the language of that contract are important because he gave me so much insight and we spent so much time going through some of these items. It looked like a college essay paper. I mean, he marked it up and he like explained, he's like, this right here, this is how this could get you in trouble. This right here, this is how this can get you in trouble, right? Like, because he has that experience. And honestly, I'll pay a specialist any day again for that help. The other one that was nice, non-compete. They had 2 years and 10-mile radius of all facilities, and they go to a lot of facilities. So it's like the majority of the county. We were able to negotiate that down to 1 year and 4 miles, and that got approved. We agreed mutually upon that. So I want to focus a little bit of time on this to understand this particular type of incentive pay. So it's a little wordy, but I have examples on the right because I asked, well, what can be expected as far as like production? This particular private practice, and I think a lot of them work this way. Some hospitals will focus on RVUs. Here, this is just cash money. And it's not production, technically. Production is what you do, and it's not the same as what you collect. So I may bill $1 million worth of pulmonary services, but some of those patients may be uninsured, underinsured, not pay their copays, disappear. There's so many situations in which you don't actually get what you build. You may bill a million, but get only 700. 30% may just be completely lost. And this is also a cost of doing business. Now, you'll notice here it's a little bit of an excess of what my pay was, so that you want to have enough to cover this as a business, enough to cover the salary of the employee and their benefits and the overhead in the malpractice, everything else that the practice is paying for, but still incentivized to a degree. So my pay was technically 380, the 36 extra was kind of on the side. So then I had to exceed here 425,000 of collection, and I got 25% of that. So I put some examples in here. So because I asked, well, what can I expect to collect? You know, what do other people, what have they collected? And I got these figures of about 500, 550, and 600. Okay, so then that means that if I produced about that much in the first year, I would get an $18,750 bonus, which would be supplementary to the 416. So not too bad. So that would put me like 434. So not too bad, right? Then this next year, if I got to 550, and in that point it's 30% of collections, that would be a $30,000 bonus. Very nice. And that was going to be doing 390 plus the 36. So I mean, like it starts to increase. And then definitely towards the end, it's 35%. And if you're really producing 600,000, collecting, not producing, I should be really clear. Producing is different, right? Then you could theoretically see a $52,500 paycheck at the end of the year as your collections. So here, some places will have varying degrees of this. And I could tell you, even from my wife, who's family medicine, when she had her contract, it was very similar to this, where it was not so much that they cared about what you did, it was what you actually brought in. Then you have to consider things I never had to consider before as a fellow, the population. So this is in a really well-insured, well-to-do county and city. So one of the things that I learned to ask is, well, what are your guys' actual collections based on billing? Like how many people are insured? And they said their collection was something in the high 90s, which is unheard of. Everyone I spoke to was like, they're probably making that number up. I mean, I never got on the other side to know if that was actually a true number or not, but I almost believe it again because it's a well-to-do area and everyone had supplementary insurance on top. No one had just Medicare. Everyone had like super fancy supplementaries that covered everything on earth. So that is a very, very particular population. So if you go somewhere more underserved, then this may actually become an issue because you may bill all you want, but you're not actually bringing in that much money because there's always basically money that just falls through and you never get paid. So again, in this type of scenario, RVU is not the priority. It's actually what are you bringing in? Now, the interesting part, which I learned about ICU compensation, right? The group is paid to cover an ICU. So I thought that was a lump sum. So let's say it's like $1 million. Here's $1 million, figure out the coverage, and the hospital's paying the practice. It doesn't work that way, at least not in this scenario. What happens is they look at how much you produce, so how much you build, all your 99291s, right? Critical care time, how much you should have made for what you actually did. And then they look at your collections. And what they do is they make you whole. So in the hospital setting, it's going to be a little bit different in the office. If you refuse to see anybody who's underinsured, then sure, you can make sure that you get the best payments and collections in the office. But in the ICU, you just treat anybody, right? Anybody that's critically ill, you got to take care of them. So if somebody comes in uninsured, the hospital is basically promising to cover the difference. So that's the way this type of scenario worked out. Now, that meant that if you were doing a month, this is now as you become partner, which we'll talk about, then you wanted ICU weeks, or really what you wanted is a really, really busy clinic day, right? Because that's where most of the money is made. But when you did critical care, you usually did, and we're not even talking about procedures. Not that procedures pay super great, but all of these things start to add up. And you'll notice the mindset of critical care, of private practice, always ends up being financial lean. There's always a financial lean. And it's just the nature of the business, I think. It doesn't make it a bad or a good thing. It's just something to be aware of. And we're going to get more into the weeds on this. Why? If you notice here, you want a packed clinic. We'll see how clinic is really probably the most efficient use of time. The other thing is you never sign off consult. My record was I saw 52 patients on a weekend. And you guys can mathematically figure out how long a day that was, because that's a lot of imaging and a lot of nebulizers to renew and a lot of stuff to go through for 52 inpatients. The details are not important. That's why I just put it like this. But it was 26 line items that the lawyer gave me. And he said, sit down with whoever's in charge, go through each and every line item together and talk about how these are basically like expectations. Again, best $850 ever spent. And again, the lawyer's giving me all these nightmare scenarios where like somebody went to lunch and got fired for cause because they went to lunch at like the wrong time. And like all these crazy scenarios that the lawyer's telling me of like how people had to like defend themselves in these bad situations. And again, it's things that we don't think about. I never thought about in my life, but there's stuff in here about what are the actual expected volume in the office. What are the time slots? Are they 40 minutes for new patients, 20 minutes, or is it 30 and 15? How is that going to change over time? How much flexibility do you actually have in your schedule? What if you don't have patients in the afternoon? Can you actually just leave? Are you supposed to just sit in your office? Like little tiny, tiny details that could be a thing. I mean, literally just how much time is for lunch and when is it expected? And is there any issue where you can't take lunch? So I think I had a very, very thorough lawyer, but some of these things are very definitely important and could become an issue if it's not clear on both sides what the expectations are, because a lot of this is just expectations. So I described it like a prenup. Like we don't want to get divorced, but this is the worst case scenario. Who's gonna get what? And that's what the negotiations were. And it didn't feel like a negotiation, honestly. The main person in this group, I consider them a friend still, like very professional. All we did was sit down. I gave him a copy. We went through it line by line. We understood each other's viewpoint and we came to a consensus on what we thought was best. Same thing with all those other line items. I mean, basically, I asked for more money. He said, we can't do that. I wanted to sign it. He said, well, we can't do that, but this is what we can do. Right. So very, very honest and open, which honestly was a very big part of why I signed, because I really liked how well this went. I felt like it was very friendly. Now, important pieces of the puzzle to understand for this partnership track is I pulled this 2024, 2023 facility, non-facility, and I just gave you like sample numbers to give you an idea. This is what you would bill potentially. So you don't really see it as a 99291. And this is the experience that I saw on the other side, right? They don't see, oh, a 99291. What they think of is that's $213.83. That's a critical care patient. And if you have a 12 patient day, you're looking at billing $2,500, right? That is what you've produced in that day. 25 patients in the office and they're level fours, which most consultant pulmonary stuff, and I actually had, by the way, education, which I really, really liked. And you can ask this if you do want to join private practice on the key elements to make sure that I did not over or underbill by a billing specialist that was employed basically as a consultant by the private practice. So they came and they were like, if you change medication management and there's one unstable thing, you can make that a level four, right? Like things that I didn't really understand. I feel like I didn't get that education as a fellow. It was kind of like, well, they're kind of complex. You give them a four. And if you call the ER and they have to be like taking an ambulance, you can write a five, right? Or you spend like an hour with something really, really complex. So getting that education, I think, was really, really nice to help my understanding. And most clinic patients in a pulmonary office are like a 99214 as a follow up. That's $128. Now, you can see that if you have 25 patients in the office, which some people will say is busy day, some people say it's not even that busy. Again, very personal. That is $3,200. So it could end up being very, very efficient to actually have a very, very busy clinic and not actually do ICU time. Because you may bill that, but half the patients may be underinsured or uninsured, and you'll be made whole later by the hospital. But your actual production and what you're bringing in, which by the way lags a couple months anyway, so this is all kind of like on a rolling basis. Being a really, really efficient pulmonologist in the office is actually very profitable. Something I had no idea. And a regular follow-up, we're not even talking about like a 99233, like the higher level one, which here is 117. Just a regular office, 35 inpatients, which sometimes we had that many, sometimes more. Again, I had that 52 record weekend. That is $2,700. Now, if you were to ask me, I'd rather have 12 ICU patients than 35 inpatient consults because honestly, it's like triple the volume. But you can see how these different types of work and different volumes can produce very, very different outcomes. And again, this is something I had never actually seen like this written out and explained. How a really busy inpatient day where you're like running around like crazy is almost as much as a pretty chill ICU day, sometimes 12 patients. And again, that's not even including procedures. This is where it gets really, really fun. Pulmonary procedures, forget critical care and like lines, they don't really pay much, but neither do bronchoscopies. So, as the person trying to bring interventional pulmonology type services to a brand new hospital, this was my biggest concern. And it's actually part of why I asked for the extra $3,000 a month. I said, I can do all the group's bronchoscopies. I have no problem. I will do everyone's ebuses. I will be your bronch man. I love bronch. But broncs don't pay. I already knew that part at least going into it. They just don't. And if I had, and I did a lot of the stuff like you'll see, I triple doubled up. I would be like in the ICU running in, doing a bronch. I'd be on inpatient with 35 patients trying to do like two EBUSs. EBUS one on one day may pay you $300. And it could be like a really technically challenging one. There could be delays. There's like so many things that are just time consuming. If it's an outpatient, you did get to bill for the consultation to see them. I usually saw them beforehand. I guess at least see my face, like who's the one that's going to stab you, right? And do the biopsy. Sometimes I did tele. So I would do a tele while in the unit for a pulmonary patient that was one of my partners to get them to see like who I was and what the procedure was so I could basically consent them and spend that time while doing something else. And then the actual procedure itself, it just doesn't pay. I think the most I ever got paid was like a 3+ station EBIS with transbronchials, with brushes, with BAL, the whole shebang. I think it was 350. And forget it if there's complications, right? Because now you're spending time talking to them about the complication, talking to the family about the complication, right? All these things, documentation. it's efficient. It's not efficient, and this is why private practices. Then I understood why private practices a lot of time don't do bronchoscopies, and they just rely on the bigger hospitals, usually with teaching programs, to do most of the procedures because it just doesn't pay. You know who it does pay, and you'll see it here is the hospitals, surgery centers, whatever it may be. They, mind you, they have to get the nursing staff and the anesthesiologists. Actually, anesthesiology feels different, but all of this is very profitable for the hospital, which is why big hospitals with teaching services, they can do bronchoscopies nonstop. And if you diagnose malignancies, then they go to their oncologists and hematologists, and then they get their radiation and they get their surgery. So it all stays within house. So I learned something called downstream revenue. And this is what the hospitals really, really care about. So from a standalone proceduralist bronchoscopy standpoint, what I learned in private practice is that it's very, very hard to sustain a IP as a private practice. It doesn't work. By the way, a stent case that you may struggle, which I did for like an hour and a half and sweat trying to get that stent just the right amount and ballooning your way through. That was a lot of fun in fellowship. That was like 180 bucks. Great job, great use of time, very efficient. The patient needed it, but at the end of the day, if you do a lot of that and you're not producing, then you don't even meet your salary. And then you start getting into trouble where your partner's like, you're not even worth your salary. You're not producing enough to pay yourself. And that can be a situation that you can get in basically. So considerations as to this whole scenario. Obviously, there's a lot of money to be made in private practice. Partnership, this is just a rough range because I never really found out because I didn't make partner. I didn't stay that long. Anywhere from $500,000 to $800,000 plus. I mean, there's whispers back in the day of people making $1 million easy. Now, if your private practice owns a surgery center, forget it. And I've kind of heard of groups like this where they're like multiple specialty and they happen to have a pulmonologist and maybe like a GI. And so you now are getting that big payment and you own the surgery center. So people that own surgery centers, like as a group, there's a lot of money to be made there. I don't even know how much. I just know it's a lot. There's a lot of different steps for buy-ins. And this is all things that you want to have a very clear understanding in when you have these discussions. So some may want to split a yearly production. So 1 year of production divided by a new total number of partners. This is an example that I have from someone that I know that they told me that they were in this situation. So it was a single solo practice. They were under them for 3 years. At the end of the, actually it was 5 years. They wanted to have a 5 year period to make partner. They said, well, I produce 900,000. So I want $450,000 from you and then I'll loop you in. It's like, that's a lot of money. Oh, well, we can figure it out or we can kind of loan it out to you. But that's a big lump sum of money to suddenly give to your partner who's been paying you. You got to give it back. I think White Coat has a really nice graph on, return on investment and time and all these things. It really shouldn't be that way. That it should be that you're getting paid less as you ramp up. And that is basically kind of like your buy-in, right? That is why there's a time period to get into the partnership. So some can finance a buy-in into the pot. This is another example that I know. So for example, let's say you have 6 people and what happens is you compare the production of everyone in comparison to the new partner. Once the new partner is reaching an equivalent level to the partners, they say, okay, well, now you're making about as much as, or producing or collecting as much as we are. So you can join the pie. Everything gets put into one place. And so let's say, for example, all of the collections for the group were $800,000. Now, 200,000 of that is overhead and all the employees and the malpractice and all this stuff. Now you have 600,000 left. You leave some in the pot, but everyone gets a payment base and then everyone takes disbursements. So the disbursements may be paid out in such a way where, well, since you had the most RVUs, you brought in out of 6 people, you brought in 20%. Like you worked a lot in the ICU or you had a crazy clinic. Well, we're going to give you you're going to get 20% of what's left over. And it's kind of divvied out like that. And this was kind of what this practice did. So obviously, if you were grinding and busting and you were making a lot, then you got your share. And sometimes that's what people will call the eat what you kill model. So if you make a lot of money and you bring in a lot of money, then you're going to make your fair share. So, for example, this practice was saying, well, if every partner is taking home 50,000 that month, and now you're going to come in that month as a new person, we're going to basically kind of loan you that money. So you'll get paid your 50,000 and then the same piece going forward, but then you'll take out 4K for 12 months because that was the one period where we started having to kind of split it. It kind of made sense. I never really got too much into the weeds of it because obviously I did left, but that's kind of how some of these models will work. You have to maintain, these are thoughts, considerations. You have to maintain your salary. This is what we're talking about with bronchoscopy. So sure, you can have a bronch day where you do like, 2 navigationals and 3 EBISs, and then you're running like into problems where you're not even bringing enough to cover your salary and your malpractice. There's all about cash flow, production, consistency of production. If you take time off, I was told, yeah, you technically have unlimited time off. But then if you're gone for 2 months, everyone else is paying your overhead. So that can be an issue. So theoretically, you have a lot of flexibility, but theoretically, you have a lot of responsibilities. And now, as a partner, they're real responsibilities. You have employees. So voting rights as a partner, that's important, obviously, if you're going to add new hospitals to cover or new partners, all these things. And later, which a lot of, unfortunately, private practice is kind of like the dying breed, is if you do sell, now you're going to get a chunk of money for a potential sale. But those sales are not really the amounts that you've probably heard of, where it's like millions and millions of dollars. That has changed and that has been undercut quite a lot. So that's not, you're not going to get a $3 million, check. Unfortunately, it doesn't kind of work out that way anymore. So pros and cons, just overall. So the environment was great, very friendly staff. This is again very narrative, cooperative all around. Monetarily, everyone's well insured, so I didn't have to worry that much about the collections. They're pretty good. Decent acuity and mixed older population. And that continued to pave the way for me for NeuroQuit. We covered the neurocritical care ICU a lot, so I was able to get NeuroQuit boarded, so that worked out great. And residents were very eager to learn. That's always important. We began the fellowship. I pushed. I got APD, which I was like very, very excited about because I really, really, again, enjoyed working with fellows. I had a heavy hand in their schedule, the didactics and everything, so I really found that enjoyable. And then I had a lot of flexibility to do the IP stuff. There was days where maybe I would have clinic in the morning and then I would have like 2 EBISs in the afternoon or vice versa. So I had a lot of flexibility with some of that aspect of my schedule. So then, we started having discussions about like dedicated block time in the operating room in the Bronx suite. There wasn't really a Bronx suite, it was all GI. I had complex cases, again, stent cases, all this fun stuff. I was involved with the thoracic tumor board. I did bronchoscopies during lunch and ICU days. There was 2 intensivists, so I was like, "Hey, man, I have a bronch real quick. Can you just, if you hear something, please help?" So that was great. But we're gonna go into what really made me go away, which is the schedule. It was 25 to 26 days a month. That's what it turned into. There was with that much time, there was no personal time, so I was trying to make sure to like handle a household and a family and there was no time for sleep because what would happen is I would get home late, take care of stuff. I would wake up early, take care of stuff, go to work, and recycle. And the problem is I love work and I loved this job. I actually really, really loved it, but I didn't want to be there every single day. So that kind of got a little bit exhausting to not be able to take care of anything else but work. I couldn't stay up to date. I had no time to just like read. I couldn't go to the gym. Like again, I'm not getting proper sleep, so it started getting a little tired. So I called it a little bit of like the Icarus moment, right? A little too close to the sun. Everything was perfect, but I had to just be in it 100% all the time. The workload that had that 52 patient weekend, I mean, that weekend was pretty terrible. It took 5 hours just to write all the notes, right? 5 minutes a note, and there's 52 of them. Actually, I think it took a little more. And then what I realized was that the interventional platform was really poor. The hospital did not understand the importance. So getting some of the things that I needed was really difficult. So I actually never really got a robot. It was just circle, 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 never got it. So I was just doing a bunch of EBISs and other things. IP requires a hospital subsidy. As you saw, the payments is just not there. So for you to be able to do this successfully, you have to have some kind of like help from the actual facility. Tumor board time, all unpaid, and I had no dedicated time for IP. Towards the end, I was kind of able to get like those half clinic days, but really I just double worked. I did IP stuff during Palm, obviously, and IP stuff during ICU, and IP stuff during neuro ICU. And the ultimate sign for me was my son started saying, "Dada, are you home?" And I was home. I was like, "Wait, what do you say when I'm not here?" And my wife sent me this picture. I'm like, okay, something has to change, right? One of the best and kind of meanest things that I heard from the one that hired me, the chief at the VA, we were having a conversation, and he said, "Well, you don't want your son to say, oh, the fellows tell me he's a really cool guy." Oof. Okay. Again, things are a little bit different now as a dad. I think completely different. I'm gonna put this here. This is a true. On the right is what I was kind of told the schedule was going to look like. I plotted it out, I put hours, and I calculated. The left is what it actually ended up being. So you'll notice on average, it was 270 hours a month, which is about, I think, 67.5 hours a week. So 60 to 70-hour weeks. And you can see the hours here 59, 62, 55, 53, 64, 73. You'll notice that there's a period from the 24th here to the 19th that there's not a single day off. And I have it here all very numerically. I have it in green for nights. Post call days don't count, by the way. And anyone that says they do, right? There's no ACG meet to protect you here because you're on your own, but you have to kind of protect yourself and say, no, those don't count. I had 14 days off. So basically, I worked 80 out of 94 compared to the 47 out of 94 in the other one. And as you can see, it turned into 1 out of 2 weekends. I mean, there were some weekends where, like, again, just straight back to back days. So the reality of what it turned into versus what was the expectation was pretty far off. I thought it was going to be 215 hours. I was like, all right, that's like 55 hours a week. That's a little bit more. No, and that's a big price to pay to do pulmonary and IP and have fellows. And here, if you put them side by side, this is what I was working, making 450, and this is what I was working, making less. The math wasn't mathing. It was hard to justify. And sure, once you get to partner, the pay will be better, and theoretically the lifestyle would be better. But no, the sacrifices, what is it? The juice wasn't worth the squeeze. And I started to see like this is not sustainable for me. This is not what I want life wise. So comes in the VA. I have it on there, and it's very widely available. This is the one I have to be least transparent about because apparently you could look up any federal employee's pay, and it's completely public knowledge. So I make a very cute 305,000 right now. Now here's the caveat though: it's 80 hours exactly every 2 weeks. So there's no more, there's no less. The way my schedule has been made is I work 6 days of ICU and one clinic day out of 14 days, 2 week blocks, a pay period. This is from their numbers, which obviously you're not going to take a bunch of sick leave, but a possible 50 to 55 days of paid leave a year. So every pay period, I get 8 hours, like how when I used to be an employee at Walgreens, you get 8 hours of vacation, which means you get 26 vacation days, 26 8-hour vacation days. You get 11 federal holidays. Everyone gets a federal holiday. So if it's a 2 week block with 4th of July, everybody works 6 days instead of 7. And if you work the holiday, it's only ICU, you get those 12 hours as an extra 12 hours off later. So you only work 68 hours instead of the 80. The sick leave, again, we're not the type of people to call in sick, but you also get 5 days of CME. So I got to go, yay, ATS, right? I was able to go, and it didn't even come out of my vacation. And I didn't have to do what I used to do with the critical care only job where I had to compress my schedule. No, I literally just got conference time. Then there's 5% match, which is really good and solid. And the thrift savings program is what they call it for the federal side of it. It's fantastic. Federal retirement is 5 years. Sorry, it should be 20 years of vesting for the federal retirement. So after 20 years, you get 20% of your pay for perpetuity if you just literally retire. So I could retire in 20 years, get 20% of my average last 3 years of pay. If you every year you keep working, you get 1 extra%. So if you work for 30 years, then as soon as you retire, you get 30% for life. So that is 100% backed by the United States government, right? So you're going to get that. You can't really get sued. Now that's kind of a technicality. There is a tort claim type of scenario. You won't get personally in trouble, but really you are protected to a large degree. Doesn't mean be reckless, but you are protected. So it's something that a lot of people stress out about. Oh my God, I could get sued at any moment. You don't have to really worry about that. CME is only $1,000, which whatever. There's no real contract. I mean, I never really signed anything. I just took an offer, and they were like, "Here's your offer. All right, cool. You can start. Here's when we'll onboard you." So, I mean, I would at least give 2 weeks notice if I ever left. But basically, like for example, the private practice, it was 4 months. So here, you don't really have those same kind of like contractual obligations. And because it's the sister site to the fellowship, I got to keep the faculty position, still work with the same fellows. And because it's a not for profit benefit in 4 years, those $440,000 will be gone, which pre tax, that's the equivalent of $160,000 extra. So really, it's like I make 465, or I would have to make that much for the next 4 years and pay up to get the loans forgiven or pay them off in 4 years if I did it outside of this situation, right? So here's the cost of doing business here, which is really nice. So the APD role had to stay with the private practice. That's what I was told. And that came with a $20,000 a year. So I lost that, never got a dollar anyway. And I was really emotionally connected to the role. So obviously that was really hard for me to have to give that up as part of leaving, even though it's to a sister site and I still see the same fellows and teach them. And the malpractice, technically I quit at 10 months because I said, I'm not working 25, 26 days in December. So I had to pay $17,286.70. That came, actually, they were very nice. And they also took that out of my paycheck pre-tax. So again, like, I like them. They're great. I just didn't want to be in that situation, but they were very, very good at taking care of these types of things in the best interest of everyone. So that was pre-tax money, which obviously made it way cheaper for me. This is what my schedule looks like now. You'll notice there's a lot of red, a lot. And this actually was a heavy 3 month period of nights because I was first starting, and I talked to the doctor that makes the schedule. I was like, "Hey, I'm on a lot of nights. Is this gonna be like this?" She's like, "Oh my god, I never noticed how many it was. I'm so sorry." So then the 3 months after this was way less nights to balance me out. So, but just to give you perspective, it's 160 hours basically every 2 weeks, right? It's only 80 hours. I worked 9 weekends. They're in there, 9 weekend days, right? Out of 26 weekend days, this is 13 weeks. And four are technically post call. So really, I worked 5 weekend days. It ends up being like 1 in 4. And 13 nights, which again, in 3 months is about 4 a month, but it ended up dropping now. I think I did like 2 last month, right? Because they're trying to like balance me out because that was just an error on their part. But this is data that I have somewhere to present it just for, again, consistency. You know, it's 160 hours. Compare that to, where is it? Oh no, I have it later. I'll just put it here because I'll looking at it, going from 186 average a month to 270 average a month to 160. I say I feel like I work part time, and this is something that I want to emphasize. I think we're all used to running at a certain speed in pulmonary and critical care, and it took time, about 2.5 years, for me to say it's okay for me to slow down. Like it's okay. I can take the time for me, my family, and whatever else I want to do in life. If I want to garden or something, it's okay. I can always work more. And kind of beating ahead, I already signed contracts to do like per diem stuff, like locums work, to supplement a little bit that pay difference. So, but the flexibility is there, and this is what works a little bit better for me. So, real quick, because I know we're running a little quick on time. Pros, the best saying I got was when I interviewed in Cali. I almost took a job in Cali coming out of fellowship. They say life work balance. They don't say work life balance. Life comes first. And I like that. So I started using that. I'm like, man, it's life first. The work comes, you gotta balance the work into the life, not the other way around. All these pension match benefits is great for the long term, so you'll be taken care of. There's way less malpractice issues. You have any state license. If you have a New York license, you want to go to Cali, you don't have to get a new license. You don't have to worry about that. Few hours that I work means I can focus on like research. I'm trying to put together IRB, like clinical research stuff. You know, I can do other gigs. I could teach. I can go to the gym. I could take care of family. Like I could travel. Like all of these things that now I can do that I finally have the time to do that I didn't have the time on during fellowship, but I didn't have it before that. And it's a vulnerable population because taking care of really really well-to-do people, sometimes not as rewarding. Sometimes they're not the super nicest and the kindest. I don't know if you guys have worked with veterans. Most of them are honestly really thankful for the care that they receive from us. So I really like that. I like underserved populations. I learned also. New York is super underserved, and I like giving back that aspect. The cons, there's a lot of bureaucracy. It's the federal, right? So there's going to be bureaucracy, but that's present everywhere. It's just different. It's a little different federal levels. Heavily male population. So I mean, I think I've seen like 3 females, and I've been here 6 months. So yeah, that's a little bit of a change, right? And the acuity is quite low. This is just the fact. If you think about it, like how many veterans are there? How many people? How many of them are going to be critically ill? So the acuity is just a little different. The threshold to come into our ICU is pretty low compared to what I'm used to. So learning that new threshold is, I mean, I had to learn it just going into the community, and then now I had to lower it even more. But again, it ends up being just what is it the patients need. And on paper, the pay is low. However, I have this is everything together. It's wordy. I said I'm sorry ahead of time because it did end up having to be wordy to get everything that I wanted message wise about these three type of practice settings. But this is again very mathematically inclined. I ended up working 2,160 hours, really. That ends up being about 442,800 plus the other little educational stuff for that many hours. But you don't have PTO, you're just an employee. So yeah, it's great money, but the connection's not there, right? You're an employee at the end of the day, and it feels like it. I mean, HCA is very, very about the money. They will get somebody fresh off fellowship and replace you. Prior practice, you are unreplaceable once you get a partner, but it's a lot of work for the potential partnership. And there are a lot of horror stories about people going through the preset time period and being told that they're still not producing enough, they're not quite ready yet, and being dragged for an extra amount of time. And some people just never signing on. So those stories exist, and I mean, they're true. But if you have an entrepreneurial mindset, all of these things, then I mean, definitely, I think I loved the job. If I was a bachelor and not yet married, and I love work, I just love work, so I would have probably made it work, and I ended up being partner. But I was not, I think, in the right time period of my life with a child now that I want to spend time with to really make that work because it was either kind of like spend all the time at work or try to spend some time with family. So the priorities are a little different at my time period. The other one then for the Veterans Affairs is, I mean, it is somebody said it best. They said they feel like they're a volunteer and they get paid to be there. Like it is very chill. I had 5 patients in clinic today. I had 5 patients. God, I spent an hour and something with almost all of them. We get to be very thorough. So the stress level is just nowhere near the same. And I don't work again until like Wednesday, and then I'm off like the weekend. And really, you saw I work 3 to 4 days a week. Sometimes I work 5 days, I work two the next one. So it gives me that flexibility to do things. So mathematically, this is where it gets important because this is the math that I did when making my decision to change. Sure, it's 305 divided by a standard 2080, which is 146 an hour. If you notice, already, even assuming a $50,000 bonus when I was in private practice, I would make 466. But 270 hours a month ends up being 3,240 hours a year. So that's the equivalent of $143 an hour. I used to make more moonlighting and covering the CCU and heart transplant when I was a fellow. Like I used to make 150. So it's hard to see the number, and it's so many hours, right? And assuming you make partner, an amazing partner pay of $700,000, I just chose that number arbitrarily, and still that many hours, that's $216 an hour. You cannot compare critical care time. Critical care always pays more. You will take a pay loss to do pulmonary. It just happens to be that way. But if you look here at the VA, man, 26 vacation days earned yearly, 8 hours every 80 hours, that is 208 hours less, 26 times 8. So that's like getting 305,000 for 108 for 1,872 hours. Now you're at $163 an hour. If you consider your 11 federal holidays, because you're going to get those off, now you're really working 1740 because it's always 12 hours. So that's $175 an hour. And then this is my particular situation. If you consider the loan forgiveness, for me, my number is 160. That's what I would have to make extra to pay it off in 4 years. It's like I'm making 465 at 1740 hours a year. It's like I'm making 267 an hour. The efficiency, I don't have to work more. The efficiency is there for me, where it's the most I'll probably ever get paid. That's basically what it feels like. For the amount of work that I put in, how much I'm getting out of it, it just makes a lot more sense. And a lot of people, what they do is they actually accrue so much continuous vacation because they don't have to use it really ever, barely, is that they take their schedule after a year or two from 6 days every 2 weeks, from 7 to 6 days, because you could take 12 hours and just knock them off. If you really wanted to, you could just take an 8 hour period, but then I would lose my clinic, and I like clinic, and then just work 72 hours. And then you could do all the other work in the world. It's very free to have the time to do more. So I tried to fit a lot in a little bit of time, but basically this is these three practice settings and everything I think I would have wanted to know.
Thank you so much
Oof.
for sharing that. I think we are over time by a little bit. Dr. Peverini is a second year internal medicine resident moderating our chat. I think we have time for maybe one question. Do you see anything in there that has come up?
Yeah, I saw one question from Alicia Bowles. You might have already mentioned, but how are you compensated for the associate director program, teaching, scheduling fellowship roles when you were in private practice partnership? I think you covered that a little bit, but maybe you could address that.
Yeah, so that is obviously going to vary by the GME. If it's university connected or just a GME, like for example, like a GME department at ACA, because they have a separate, pays for everything. And it's something that is also negotiable. But at least what was budgeted and what it is supposed to be in my particular situation, it was $20,000 lump sum. Now, the way that it's supposed to work by ACGME, there's a designated period of FTE, full time employee, that is supposed to be compensated so that as an employee, you can take that time to not work and dedicate it to those, let's say, administrative activities. So here, there wasn't really like a specific amount set on that. It's also more for, like, for example, for a program director, where ACGME dictates that you should have FTE time to dedicate to being a program director. So they have cutoffs, and the numbers should kind of match what the pay is to basically compensate you for that time. But in this particular scenario, it was 20K just for the work.
Thank you so much. I'm realizing we should have a session on academic pulmonary critical care. It's so different from what you've been doing. This is super enlightening. Thank you. Thank you for being so transparent. Thank you for being so vulnerable. Thank you for sharing your experiences. I think we all learned a lot.
No, thank you for having me. Again, things I think I wish I could have known.
Yeah, absolutely. All right, everyone. Thanks so much for joining us. I hope you have a good rest of your day.
Thank you. Take care.